Beautiful. Okay, welcome everyone as everyone starts to enter. Before we begin, I'd like to advise those participating that we will be recording tonight's session. So good evening, everyone, on behalf of Eastern Melbourne Primary Health Network and Banksia Palliative Care. I wish to welcome everyone to the role of the GP in prescribing opioids for palliative care patients webinar. My name is Sonia Mbezi, and I am the Palliative Care Program Facilitator here at Eastern Melbourne Primary Health Network, and I have previously worked as a physiotherapist for the last 12 years in palliative care. Now, before we begin, I would like to start with an acknowledgement of country. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nations whose unceded lands our work in the community takes place. We pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past and present. EMPHN is committed to the healing of country, working towards equity in health outcomes, and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box, which Chien will be manning for us throughout the session. And if we have any time at the end, we will talk to some of these points too. So just a little bit about the primary health networks and us working here at Eastern Melbourne Primary Health Network. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. The PHNs achieved this goal by improving access to existing services, commissioning services to improve health outcomes, and supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. So tonight's event will focus on the role of the GP in prescribing opioids for palliative care patients. This informative session will equip healthcare professionals with the knowledge and skills required to select appropriate opioids for effectively managing pain and dyspnea in palliative care patients. We will also address the crucial medico-legal aspects of providing opioid prescriptions for palliative care, ensuring compliance and patient well-being in the community. And now to introduce our presenters. So Dr. Chien is a palliative medicine specialist consultant serving various hospitals and community palliative care services in Victoria, including Banksia Palliative Care. On Saturdays, he also practices as a general practitioner. His dedication is steadfast, focused on supporting individuals with progressive, incurable diseases to improve their quality of life despite the challenges of illness and end-of-life care. Beyond his clinical responsibilities, Chien tirelessly works to enhance community care through both his clinical and administrative roles. Moreover, he actively engages in teaching and mentoring medical students and specialist trainees, fostering a culture of academic excellence and compassionate care across all clinical environments. Wendy is a registered nurse with over 30 years' experience, with a significant amount of that time being spent as a community palliative care nurse. She is currently the Training and Development Consultant at Banksia, responsible for internal and community education. Wendy is passionate about best possible palliative care outcomes for people living with a life-limiting condition. Dr. Ruwani is both a consultant palliative care physician and a medical oncologist. She specialises in managing cancer-related symptoms and providing supportive care, particularly in breast cancer. Trained at the University of Adelaide and with extensive experience in Melbourne and British Columbia, she currently holds appointments at Western Health and Peter MacCallum Cancer Centre. Additionally, she works with Banksia Palliative Care, focusing on community-based palliative care in Melbourne's northeastern suburbs. And finally, Crystal. Crystal has been registered nurse for over 20 years with 15 years experience as a nurse immuniser. Her passion lies in public and community health education and communicable diseases. Throughout her career, Crystal has gained extensive experience in diverse roles, including aged care, ward nursing, and international humanitarian aid missions. She currently holds the role as the HealthPathways Program Specialist with Eastern Melbourne Primary Health Network. And with that, I'm going to hand over to Crystal, and she's now going to speak to you a little bit about HealthPathways. Thank you, Crystal.
Thank you very much, Sonia. Greatly appreciated. And thank you, everyone, for having me here today. I'm going to talk to you about HealthPathways and hopefully how this can be a great resource for you at the point of care with your patients. If you just give me a moment and I shall get this one going. Okay, here we go. Welcome to HealthPathways. HealthPathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne Primary Healthcare Networks in partnership with healthcare professionals and organisations in the Melbourne region. HealthPathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate HealthPathways Melbourne to find relevant pathways to support GPs on prescribing opioids for palliative care patients. Navigating HealthPathways. Visit the HealthPathways Melbourne website and log on. Here you will find the homepage with the latest news section, as well as pathway updates. Search for the relevant pathway by using the table of contents on the left-hand side. Alternatively, you can use a search bar at the top and enter relative search terms, such as pain in palliative care. There are over 40 pages in the palliative care suite. Today we're looking at pain medications in palliative care. A clinical editor's note, as you can see here, is a concise temporary edition offering a succinct updates on broader health system developments. These notes serve as valuable insights into the current healthcare practices, as shown here with the palliative care to access core medicines, as well as the core medicines list. The management section provides a concise list of steps users may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway provide supplementary information, shown here under the moderate to severe pain and the drop box for strong opioids. Additionally, the page will offer links out to other important resources, shown here with Safer Care Victoria Opioid Conversion Ratios Guidance Document, and links to relevant pathways, as shown here with the terminal phase and syringe drivers. Clicking on the link will take us to the terminal phase management page. On this page, as we go down, it will provide us with additional information to consider, such as reviewing the patient's goals of care and linking out to advanced care planning. Additionally, under the management section, you'll find here managing symptoms such as dyspnea. Returning to our original page, as we go down the page we can come to the referral section. This section includes locally relevant requests and referrals that the clinician might request from a third party for their patient, as shown here. We can arrange an urgent palliative care review, or we can go to the specialist palliative care services. This page provides information on private and public palliative care services localised to the region, as shown here. Under Eastern Melbourne, we have the Banksia Palliative Care Services, which has the service-specific criteria and information for the referrer. Returning to our original pathway, at the bottom of the page you'll find the information section, which has a selective list of links to useful information specific to healthcare professionals and patients. There are over 40 palliative care pages available on the HealthPathways Melbourne site, which include clinical referrals and resource pages. The following two slides provide a list of relevant and related pathways for prescribing opioids for palliative care patients. To access Health Pathways Melbourne, go to the website address at melbourne.healthpathways.org.au. It's available to general practice teams and other clinicians in the Eastern Melbourne and Northwestern Melbourne PHN catchments. If you don't have access yet, you can just scan the QR code there or send us an email through to info@healthpathways.org.au.
Thank you very much, and I'll pass over to Wendy.
Thank you. Ruwani, I think you're assisting with this sharing of the slides. Thank you.
Can you hear me?
Yep.
Wendy, are you starting to speak or shall I speak?
No, you can. That's okay.
All right, okay. Okay, thank you for the introduction. So today we are going to talk about prescribing opioids in palliative care and the role of the general practitioner. So the goals of this talk is to give you a general understanding of commonly encountered opioids in palliative care. And also to talk a little bit about requests that are made to you from our nurses who work in community palliative care when it comes to opioid prescribing. It will also cover PBS requirements for opioid prescribing. What it will not be is a detailed presentation of the molecular and pharmacodynamics of opioids, and we will not be talking about opioids in chronic non-malignant pain. So unfortunately, many of you will know there's a variety of opioids that have recently been discontinued. So that's a bit of a problem for us who prescribe these drugs commonly. Mandi Pharma, the pharmaceutical group that makes things like Oxynorm and Sevredol, have given notice that they are going to phase these drugs out. So at this point in time, we are seeking alternatives, and hopefully we will get them as these are phased out. So when patients are linked in with community palliative care, their general practitioner, that is you, continue to be the primary prescriber of opioids. And I thought about what situations you will be needing to prescribe opioids to these patients. And I came up with 4 kind of scenarios. One is to manage the acute symptoms, which is usually pain and shortness of breath, where we use opioids. The second and third scenarios are when our nurses will request you to prescribe. That is for anticipatory medication, which we will go into, and for support in end of life situation, which we will also talk about. And the final one is the situation where you will be prescribing the patient's regular opioid medication. So we'll start with the first one, which is acute symptom management. As I said, in community palliative care patients, opioids are commonly used to manage pain. And this pain is by and large cancer pain. And then there's shortness of breath or dyspnea. And dyspnea can be caused by cancer, so lung cancer, malignant effusions, and lymphangitis sort of thing. And also from progressive lung disease and COPD and that sort of thing. Opioids, just a little bit of background about opioids. Opioid medications act on opioid receptors in the brain and spinal cord. They are grouped into strong opioids, which are your drugs like morphine, hydromorphone, fentanyl, and methadone. And then there are weak opioids, things like tapentadol, codeine, buprenorphine, those drugs. When we manage cancer pain, the evidence is for the use of strong opioids in small doses rather than using weak opioids. So you will use a small dose of morphine or oxycodone to manage cancer pain rather than starting a patient on buprenorphine or Palexia or any of those things. There's this concept of a background medication. So something in the background that gives a cover throughout the day. This is usually a long-acting preparation of medication, long-acting or modified release or sustained release that is given as a regular tablet once or twice a day. And then this concept of breakthrough doses or rescue doses that you take during the day if you were to get pain despite taking your background regular medicine. So the background dose is usually calculated to be a 1/6 to a 1/10 of your total daily dose of opioids. And where possible, we use the same drug. So if you use OxyContin as your background, we'll try to use endone as your immediate release. If you use MS-Contin as your background, we try to use morphine liquid or morphine quick release tablets as your quick acting. And it is important to remember that constipation is a side effect of opioid that is dose dependent. And it is important to remember to prescribe aperients at the time you initially prescribe the opioids. So this is a diagram that represents the use of breakthrough cancer pain. So you have your background pain, and then you get these spikes of breakthrough pain. The breakthrough pain can be spontaneous, where there's no trigger, it just happens whenever. And then there's incident pain, where you know what the trigger is. When you move in a certain way, you get the pain, and that can be predictable or unpredictable. Now you might ask, what's the point of opioids? What's the point of learning about opioids or prescribing opioids? Well, do they work? And the evidence indeed is to say that, well, they do work. if you take 20 people with moderate to severe cancer pain, opioids can reduce this pain to mild or no pain in the vast majority, so 19 out of those 20 people within 2 weeks, if they can tolerate the side effects. Most people will have side effects, and the most common side effects are constipation, nausea, and vomiting, which are usually manageable. A small number, like 1 or 2 out of 10 people, will require a change in treatment because they have side effects. So by and large, opioids work to treat pain. Side effects, initial side effects, drowsiness, nausea, and vomiting. People often can feel drowsy when you start opioids. They can also feel drowsy when you increase their dose. But usually, if they were to persevere, within 48, 72 hours, the drowsiness kind of settles. So we like to think that drowsiness and nausea, vomiting. So nausea and vomiting we can treat with concurrent antiemetics. And these side effects are, we like to think of them as expected side effects that we can manage rather than allergies or intolerances. A common ongoing side effect is constipation. As I said, most opioids cause constipation, and when you increase the dose, the constipation gets worse, and it's very important to manage it with concurrent aperients and other non-pharmacological measures. And of course, there are other side effects of opioids. Thankfully, these are rare. Things like physiological dependence, we worry less about in palliative care, given the prognosis and other goals of care. Lots of people are concerned if you ask a medical student about respiratory depression, but if you were to use it under supervision and in an educated way, it's not something that we see very often. So how do you start opioids in a patient with cancer pain? So when we start opioids de novo, we start usually with the immediate release preparation. So the immediate release version of morphine, as most of you know, is called Referral tablets. Immediate release version of oxycodone is endone. So we can start either of these on an as-needed basis. If you find that the patient is needing many breakthrough doses to keep them comfortable through the day, that means they need a background. So the background works well in the background, and then you use the breakthrough as necessary. Then you up-titrate slowly based on the background use. It's important to note that with opioids, there's no upper limit. So if you were to prescribe your hypertensives or your cholesterol tablets, for example, you look in the MIMS, it'll say divided doses to a max of this amount. But there's no maximum dose in opioids. It's very variable depending on the person. One person will get lots of side effects with 10 milligrams, whereas another person will need 100 milligrams or more to keep them comfortable, and they won't have side effects. So it's very variable. And the top dose is decided by toxicity. So dose limiting toxicity. So at the point where people feel too sleepy to carry out their activities, where they have hallucinations or delirium or myoclonus, that is what we use to determine the ceiling dose. In my practice, I say that up to 3 breakthrough doses are okay if patients are comfortable most of the time. So when I feel I need to increase my breakthrough, the question I ask is, are you comfortable most of the time? So if patients are comfortable most of the time, there's usually no need to increase the background. But if they are not comfortable, then a background increase may be necessary. So I'll take you through the commonly used encountered opioids in cancer pain management. So strong opioids, what we normally use in practice in day-to-day is, the most common one is morphine, which most of you will be very familiar with. Then there's oxycodone and hydromorphone. Then there's also fentanyl, which is slightly difficult to get in the community and we don't use as much. And methadone, we are using increasingly in palliative care to manage complex pain. Most commonly, it's used as an adjunct, which means that the patients are usually on a different opioid, so morphine, oxycodone, or hydromorphone, and then there's a little bit of methadone added on top to enhance or for synergistic effect. All right. So this may look complicated, but it's not. On the first column on the left, I have morphine, then oxycodone, and right at the bottom, hydromorphone. The relative potency increases as you go down. So the oxycodone is 1.5 times as strong as morphine, and then hydromorphone is 5 times as strong as morphine. All these drugs are metabolized in the liver and excreted by the kidneys. Morphine has active metabolites, which is why we avoid it in people with renal impairment, because the active metabolites accumulate and then cause problems such as neurotoxicity and confusion and seizures in worst case scenario. As you go down the list, the active metabolites decrease. So oxycodone has less active metabolites and hydromorphone has even less active metabolites. So in the community, in people with renal impairment, our preferred drug is hydromorphone. The safest drug, I think, is fentanyl, but fentanyl is hard to get and it is large volume, so it doesn't always fit in our syringe drivers. So hydromorphone is what we use when the kidneys don't work. Then these drugs come in various formulations, immediate release formulations and sustained release formulations. Immediate release formulations of all of these work in about 15 to 30 minutes and work for about 4 hours. So if a patient were to take an endone tablet, it'll be out of their system in 4 hours. Yeah, so morphine, there's injectable morphine. Oxycodone also comes in injectable, but it's not available in the community. So we don't have access to it. They do use it in the hospitals, but not a good thing to have start in a community patient. Hydromorphone comes in injections. The long-acting formulation of hydromorphone, which was called Genista, has already been withdrawn. As I said earlier, it was one of the first drugs to go. So we don't have a long-acting hydromorphone to use, but these other things are available. Fentanyl comes in patches, as you know, so that's the only one of the strong opioids that we get in patch form. There's also a submucosal lozenge form or called Abstro, which is really good for breakthrough or incident pain because it starts working very quickly and it goes away very quickly too. So it's very beneficial in some incident pain. Fentanyl is supposed to be the least constipating of the lot, but you still get constipation even with fentanyl. Methadone is good for complex pain. The problem with methadone is that it has very tricky pharmacology, which I won't go into. You need to start at very low doses, titrate very slowly, and it is to be used under specialist guidance. It covers a variety of receptors more than the other opioids. So when pain gets hard to manage, it's a good drug to introduce. It comes in tablet form, only one strength, physiptone 10 milligrams, and injectable methadone is available as well. Are there any questions so far, Chien, to answer, or should I just keep talking?
Nothing to discuss. Now, I know, because Bonnie did hand over, I think potentially one of the attendees may have recent encounter with methadone, and just wanted to reassure everyone that methadone certainly can be prescribed by general practitioners as well, and but we're all very happy to be involved in dosing it if you're not experienced with it. And there often can be distracted by the S100 permit situation, and but really using methadone for pain is just a usual assay requirement, which is exempt in palliative care patients unless they're previously drug dependent. So again, if there's any questions, very happy to answer on the spot, but also just ring us from at point of care day to day. So we'll talk about how generally there's a 24/7 service or at least most hours during the day who can answer these questions.
Yeah. Yeah, I agree with Chien. I mean, if you have any opioids, especially if you work in our area, and if you have any questions, there's a doctor at Banksia every day. And we are very approachable, and we understand and appreciate that you may not, you don't work with these drugs every day. So we are more than happy to receive calls, answer calls, and generally be of assistance. I couldn't manage, someone's blood pressure to save my life. So I'm very, I'm very, very cognizant of how much I don't know. So I'm very happy to help out if ever I can. I'm very good at this because I do it every day. That's the only reason. I'm sure you're good at a variety of other things that I'm terrible at. Anyway, so Targin versus OxyContin. So the difference, so Targin is, so many people ask what's the difference between Targin and OxyContin. So Targin is simply oxycodone plus the opioid antagonist naloxone, whereas OxyContin is just pure oxycodone. They went and tagged on this naloxone to the oxycodone in the hope that it will reverse opioid-related constipation. It was meant only to work in the gut. So it was meant to oppose the oxycodone only in the gut and not disturb the function elsewhere. But in practice, especially when there is liver impairment, we find that the naloxone component hangs around because it's not metabolized well as in someone with normal liver. And then the naloxone starts inhibiting the oxycodone, so the oxycodone doesn't work well. So in practice, how that impacts our practice is if there is liver dysfunction or if there's liver metastases where there potentially can be liver failure or liver dysfunction, we generally avoid using Targin and we use pure OxyContin. Weak opioids, we don't usually use in cancer pain. However, if patients are having intolerable side effects with strong opioids, and you see that in the elderly especially, then it is very reasonable to start buprenorphine or tapentadol. I have quite a few elderly ladies who didn't tolerate even the lowest dose of the strong opioids and are doing very well on Palaksia. So if it works and if the side effects are tolerable, well, then we can go for it. Generally, codeine, I personally avoid. I find that it is very constipating. And now we have other options, so there's no need really to use codeine. And tramadol also, the population of patients who are usually in palliative care, the elderly, people with comorbidities can easily go into delirium So tramadol I avoid. So this is about buprenorphine, which you can read. Buprenorphine also comes in patches, 7-day patches, as opposed to fentanyl patches, which are 3-day patches. And another slide about tapentadol, which you can read. The second symptom that you will be approached to use opioids for is to manage shortness of breath. The majority of evidence for the use of opioids in breathlessness is with morphine, just because it's been around for ages and it's been the one that's most commonly studied. Other opioids like oxycodone and hydromorphone, we sometimes use, but fentanyl, there's no evidence for the use of fentanyl in dyspnea. Other ones we sometimes use because if they're already on it for pain. The current evidence shows that we can use up to 40 milligrams of sustained release morphine a day. Some will say 30, but 30 or 40 to manage shortness of breath. The difference between opioids for pain and opioids for shortness of breath is with pain, there's no top dose. You go up as long as it's working and the patient is tolerating. Not so for dyspnea. For dyspnea, you don't keep going up because the patient is breathless. If you're at 40 and it hasn't worked, well, it's not going to work. So there's no point increasing it further. And there's certainly no evidence for use of long-acting morphine beyond 40 milligrams for dyspnea. The only long-acting opioids that's listed on the PBS for dyspnea is Kapanol. So MS-Contin, well, I use it for dyspnea, but it is well off-label then. Only Kapanol is on the PBS. In practice, if someone is already on endone for pain and they also have shortness of breath, I use interchange. Used it for both. I asked them to take it for both. And for dyspnea, I asked them to use opioids in 2 ways. One is they use it when they are short of breath. So when they're acutely short of breath or having a coughing fit, they can use it to relieve themselves of the symptoms. They can also use it prior to activities that they know will make their shortness of breath worse. So sometimes people, their shower makes their breathing worse. Sometimes they know which activities make the breathing worse. So you ask them to take it 30 minutes more or 30 minutes before they do that activity. It is contentious what the evidence for immediate release opioids is with shortness of breath. There have been some studies, a small number of studies done that say that immediate release morphine, that is Odine, doesn't really make a difference to your shortness of breath. But I don't think there's consensus because those studies are new and it's 1 or 2 studies. So that's still something that is being discussed. But certainly for long-acting opioids, there is evidence and you can use up to 40 milligrams a day. There's a lot of barriers to appropriate opioid use in the community, and these come from doctors and they also come from patients. Doctors, well, are human, so they have sometimes have fixed prescribing patterns, the fear of prescribing, lack of time, and there's all these ever-changing rules and regulations that are very, very difficult, honestly, to keep on top of. Even for someone who does it all the time like me, I just cannot keep on top of them, so I can appreciate the difficulty. Patient factors, there's cultural factors, there's fear of opioids. People have all kinds of fears when it comes to opioids. Some people think that, oh, I'm giving you morphine for pain, so does that mean I'm going to die? You know, morphine is usually associated with death and dying. And then it's not. Opioids can be used at different stages of disease to manage your symptoms. Then people think, oh, if I start on morphine, will I die quicker? Actually, you don't. There's even evidence to show that in 1 or 2 studies, people have lived longer because their symptoms have been better managed and they have indeed been more comfortable. So there's no evidence that using morphine to manage symptoms properly makes you die faster. Then people are always scared of addiction. And I guess there is a theoretical risk of physiological dependence with any of these opioids. But in the context of goals of care, if a patient's prognosis is poor, managing symptoms takes precedence over the small possible risks of physiological dependence. And tolerance is also sometimes a problem. So there are lots of these opioid conversion tables available. I would recommend that you find a trustworthy one and keep using one. The ones that pop up on the internet on Google are sometimes wrong. So I wouldn't just ask you to put it onto any calculator that pops up. This one from EPC, I use very commonly and regularly. This is a trustworthy resource. So yeah, so just get anything trustworthy and use it and become familiar with it. Patches. A quick word about patches. So patches come fentanyl patches and buprenorphine patches. Fentanyl patches we change every 3 days, and buprenorphine patches we change every 7 days. Now, the smallest fentanyl patch is a 12 microgram per hour patch. It sounds small. 12 sounds like a small number, but in fact, a 12 microgram fentanyl patch releases the equivalent of about 35 milligrams of oral morphine a day. So it's not something that you will start someone who's opioid naive, even though it's the smallest dose of patch available. Fentanyl is a very strong drug. Patches are very bad for titrating. So if someone's pain is unstable and you start with a 12 patch, the next strength of patch is 25. So you can't make small adjustments. So you wouldn't start someone on a patch who's never been on opioids before. You would wait for the pain to be stable before you switch them for a patch. Some people have trouble with the adhesive. In some people, it just doesn't stick. It keeps coming off. You need some fat underneath your patch for the drug to be absorbed. So if people are very skinny and cachectic, you'll find the patches don't work as well. And in some people, we end up changing the patches every 2 days because on third day, they get more pain, which is what we call end of dose failure. So in not a lot of people, we have to ask them to change the patch every 2 days. So a patch is good for someone who has been on another opioid and have now stable pain. And for whatever reason, they don't want to take as many tablets compared to before, or if for some reason we suspect them to have absorption problems. If we don't trust their gut, then a patch is a very good option to bypass the digestive tract. People with bowel obstructions, people with malignancies of the bowels, that's a good option. So these are, again, the equivalents of the patches. So that was when GPs prescribe opioids to manage symptoms. The other 2 occasions when GPs will have to prescribe opioids for community palliative care patients is for this concept of anticipatory medications and for end-of-life care support. So our nurses will be approaching you when they assess a patient as needing anticipatory medications. Wendy, do you want to talk? I've got these forms that you send to doctors. Do you want to talk a bit about when you send them and what you expect from the doctors?
Yeah, thanks, Ruwani. So when the nurses are visiting and we find that there is a prediction of deterioration and things are starting to change, so we think, oh, we probably might need to get some of these anticipatory medications in the home for when things do change for that person. So we make a phone call to the GP, but we also send these letters, these via fax, and there is the first one will have a description of what's going on, what our concerns are, what's changing for the person. And then with that, it has the suggested medications with doses. And also just with that consideration, if there is renal impairment, then hydromorphone is the preferred medication. But also we do encourage, a phone call to our doctors if you're ever needing support in that regard. We'd like to get these medications in the home sooner rather than later. Sometimes it does seem a bit early for some. However, often things can change quickly, and it's often the time that we need those medications with orders. So along with that information, with the letter explaining what we need and why we need it, and then a blank form for orders, for the written orders. Just there's an example there, but certainly always ring if you're not sure. And we do prefer this sooner rather than later, because often, as you can appreciate, it often happens on a Friday evening or the weekend, or we just like to preempt and make sure that the family, the client and the family have everything there as required. And it does really try and avoid those hospital admissions if the goals of care and the preferred side of care is at home. So hopefully, I think that
Yep, great. Thanks, Wendy.
yeah, no worries.
Yeah. So anticipatory medications. So anticipatory medications, if you may not be familiar with what that is, so that is basically injectable medicine that we have in patients' homes. As Wendy said, cancer symptoms are very dynamic. Symptoms change very quickly without much warning. And then the whole point is that they have the capacity to call community palliative care nurses. They'll give Wendy a call, for example, in the emergency number. But Wendy doesn't carry medicine. She goes to the patient's home, and all she has to work with is whatever is there. So if there's nothing there, well, she has nothing to do, because, well, she can talk to the patient and provide reassurance, but she can't provide anything beyond that. So this is where we have to equip our nurses to, well, do something, because they have a lot of skills. And if you can give some pain relief or some antiemetic or some whatever we can give to keep them comfortable. So sometimes it's for people who want to stay home, so then their symptoms are managed. Sometimes infusions are hung up and they remain at home. Other times it's just to keep them comfortable till plans are made. The plan may be to go to emergency or to go to hospital or to go to the private hospital. So while that happens, the patient is comfortable because they've just been given an injectable jab of something to stop them from vomiting, for example. So this is how, prevent hospital admissions. And if the doctor is away, those things are necessary. So in this, we have something for pain. Morphine we use very commonly. If the kidneys are not working, the nurses will ask for hydromorphone. Haloperidol we use as an anti-nausea medication and also for agitation. So in people who are delirious, terminal delirium is something we see very often. It is when people become confused and agitation as they near death, and haloperidol injectable is a good drug. For people who have, for example, hepatic encephalopathy or uremia due to renal impairment, haloperidol is great because it works for the nausea and it also works for the delirium. So that's why we use that commonly. Buscopan, we use for people who have, well, secretions. It's an anti-secretory. As you know, it's an anticholinergic agent. For people who have bowel obstructions, for example, where we want to reduce the secretory load, the nurses will ask for Buscopan. Then we also have here clonazepam. Clonazepam is a benzodiazepine. It is available on the PBS for palliative care. It is drops. It comes in drops that you can put in the mouth, and once again, the benefit is that it can be self-administered. So if the patient is really agitated, the nurse will pick up the phone and say, look, your mom, dad is very agitated. Why don't you give them 2 drops of clonazepam? We will come and see the patient. So once again, it gives the family the empowerment or the capability to do something while plans are made. Now, what to write in these syringe drivers can be, I don't know if you find it tricky, you may or may not, but if ever you need assistance, well, we are very, very happy to be called and happy to assist in any way that I can. So this anticipatory medicine. So how you may wonder how is it used in the community? So the nurses go in if someone is for example, if someone's deteriorated, the nurses go in and they insert. Wendy, you can tell them what you do.
Okay. Yeah. So if we are asked to visit and things are changing, we will, and the medication, we have everything we need in the home. We will insert a subcut intima and draw up medications for the person and administer as appropriate. And we also we educate the family regarding these medications as well and how to administer. If it's indicated for a syringe driver, then we would again get the syringe driver orders, and that's when clients, they're starting to, they can't swallow and things are deteriorating for them, and also to minimise stress within the household with regards to giving multiple breakthroughs or subcutaneous breakthroughs. Then a syringe driver would be commenced, which does assist definitely to help with managing best symptom management, symptom control, actually, rather than those peaks and troughs like the breakthrough pain that Ruwani was talking about. And we visit every day for that, and that is very closely monitored. Yeah, I think that's...
Yep, super.
Yeah.
And to continue, syringe driver, Wendy spoke about it. That's a continuous infusion of whatever you want to put in it, opioids, benzodiazepine, antiemetic. Drugs can be combined into one syringe driver. We use it for people, well, when they can't swallow, which often happens at the end of life if they have problems where we are worried about their absorption. As Wendy said, it's better drug delivery with a stable profile, easy for the family. Yeah. So sometimes the nurses may ask you for a range. For example, if you're prescribing for Eve, in this example, she is on 60 milligrams twice a day of MS Contin. So her daily dose of MS Contin is 120 because it's 60 BD. So 120 milligrams of oral morphine. When you convert to subcut, you divide by 3, and that's 40. So Eve will need 40 milligrams of morphine in her continuous infusion daily to deliver that dose that she normally takes through the mouth. Now, you may or may not be comfortable to give a range. So you would say, start at 40 because that's what she normally takes, but I give authority for 40 to 60 or 40 to 70. So the nurse will go talk to you on Friday, but when they go on Saturday and Sunday, they can increase the dose if the patient is uncomfortable or if they've used lots of breakthroughs. At Banksia, junior nurses or inexperienced nurses usually don't make decisions by themselves. They always ring a senior nurse or the desk nurse, as we call it, for advice before they make changes. So things are supervised. People just don't go and make, willy-nilly choices as opposed to opioid doses. So your orders are treated with respect and caution. The last topic is where you will be prescribing opioids is, of course, when you prescribe the patient's regular opioids. As I said before, GPs remain the primary prescriber, and thank you for doing that. And a lot of GPs think that you need a permit to prescribe opioids, but you don't for palliative care. For any patients having palliative care, any GP can prescribe their opioids. At present, many of you may be aware, and Chien can help me out here, there's the HPOS that you can do it online, and which give you 1 month and 2 repeats of your long-acting medicines, which is great because in the past, a call to the PBS gave you 1 month of your long-acting. But now with the HPOS, you get 3 months. But the short-acting, you still only get a month. So, yeah. Do you have anything to add to that, Chien?
No. I think I mean actually in terms of SafeScript, a lot of the permit requirements has been superseded because SafeScript is there, but technically palliative care patients are exempt. So if you're in a hurry and are unable to check SafeScript, technically it's actually not required for palliative care patients. And your pharmacy generally will check it anyway. A lot of the alerts are attached to the practice software. So if it blocks you from prescribing, chances are you just need to use the practice software to check SafeScript rather than having the SafeScript open before that, and then proceed. But it's technically not a requirement. So everything is only if the person is drug dependent.
Yep. Patients, one of the things when I see these patients in the community, one of the things that they really are worried about is their ongoing supply of prescribed medication. Now, they are worried that they might be perceived as being drug seeking. They're worried that their opioids might be running out. Most patients, when they reach the stage where they need community palliative care, they have limited mobility and can't always get to the doctors to obtain their medication supply. So that is when telehealth and home visits will come in handy. I ask my patients to make 3 or 4 weekly standing appointments with their GP so that they don't get caught out. Because this is an additional source of stress for people who are already very stressed. So I think at least that, if that can be streamlined in some way, it makes people's lives easier. I know all of you are busy, so I can understand the time requirements to go into HPOS and do 1 month's authority. But it's a balance, and I think it'll be helpful to this cohort of patients. So yeah. So SafeScript Chien spoke about. For terminal patients, I do 1 week with repeats. Otherwise, the patients end up with lots of medicine at home. The palliative care section of PBS has streamlined authorities for most things, so you don't need to call up. For example, injectable morphine, you can get 10 vials on the palliative care one, and there's a streamlined authority code. So you don't always have to call up for these things. And I think we are out of time for the little thing, so we will stop. I will pass and Chien your bit.
Thanks, Ruwani. And thank you all for coming again. And please ask any other questions. And actually, there is a question there just now. Thanks. Would OxyContin and regular bowel appearance be better for all patients into Targin? Look, we're probably biased in palliative care only because our patients often do run into liver derangements at some stage. So it does create, the naloxone does create more unpredictability in it. Saying that though, it is, and the other side is often they do need to learn to use laxatives even when they're on Targin, although there's no question they probably need more on OxyContin. So it's not black and white, and I think it's not wrong to start with Targin. There are other sort of divergent prevention / deterring qualities of because injecting Targin really isn't the same as injecting OxyContin because of naloxone. So maybe there are other benefits of it. I think keeping it in mind and making sure that we know to remove the naloxone if it's not working, rather than just blindly increasing it, I think is probably the key. Again, just give us a call, really. And yes, we more often than not just use OxyContin ourselves and with bowel periods for our patients. So with the referrals, again, anyone can refer, but definitely we do need the health professionals and their history, and we do try to get the GP back engaged and back on board. So we work in a team. And the GP is definitely one of the crucial member of ongoing care for all our patients. It's mainly a nursing service, and but yes, we are available every day and try to support and provide additional advice as required. So there's our website, but if you're out of the catchment, and you can go to Palcare Victoria to look up who's in your catchment. We go to the next slide. Just very quickly, there are many other services around. We all work closely together. So even if you escalate it to other services, chances are they'll be handed over back to us eventually. So no fret. Someone who's not on the service under any community palliative care, the Palcare Advisory Service is statewide, opens from 7 to 10, and that number is widely available. Anyone can ring, but even more useful if you're the healthcare professional ringing, because they can advise you more specifically than to the patients who they don't know. Hospital-based healthcare services, there are many services, including outreach services as well. But the reminder is they're all short-term, super short-term services, and they're all transitional services. So they're not like the community services who do remain involved, but they work together with you to look after the patients. Next slide, sorry. Very quickly, there are also research trials available, mainly for symptom management trials, and this is how we know how to prove things that work and make sure we work on what we've got and collect data. And so, if your patients are interested, there are the trials and locally, and just give Banksia a ring and let us know, and we can make the referrals too. So that's it from my end as well. And I'll hand back over to Sonia for the final housekeeping.
Thank you very much, Ruwani. Could you just head to the last slide for me? Perfect. Okay, thank you everyone for joining tonight's session. It's been a pleasure to have you all here, and I hope you've learned a lot about opioids in palliative care. By participating in tonight's RACG accredited event, you will gain 1 hour of educational activities, which I will lodge on your behalf. So that we can further improve these education workshops, I implore you to please scan the QR code on the left of your screen. At the end of this session, there'll also be a link that pops up where you can provide feedbacks to us, so we'd love to hear from you. If you haven't already done so, please register for the next session, which is next Wednesday, 7 o'clock Zoom, and that is on management of nausea, vomiting, and other palliative care symptoms in the community. And that's the 5th and final part of the series with Banksia. So you can do that by scanning the QR code on the right-hand side. There will be a follow-up email that everyone will receive, which will have a copy of the presentation slides from tonight and any other additional relevant resources. You'll also receive certificates within the next 4 weeks of this session from EMPHN. So thank you all for your time and attention tonight, and from all of us, have a lovely evening, and we'll hope to see you next week. Bye for now.
Thanks, everyone.
Bye.